presenting?
Myself, Kamlesh, sir. Dr. Kamlesh. We will be presenting, sir.
Yes, sir. So we can start.
Correct. Start.
A 22-year-old male came with the chief complaint of abdominal swelling since 4 months.
Okay, I want to know the character and extent of the swelling. Is it a parietal or a intra-abdominal?
Yeah. Anything else you would like to know?
Yeah, the progress of the swelling actually. So how it started. So now what's.
So he was relatively asymptomatic before 4 months. While bathing, he noticed a golf ball size swelling in the right side of abdomen. Initially, it was painless, but he often developed insidious onset lacking pain for which he took medical care. He was admitted 2 to 3 times for that, for the pain only. And within 4 months, the swelling has increased twice in its size to a cricket ball size, right?
Okay, I want to know whether patient has got any limb edema, scrotal swelling,
Okay.
or breathing difficulty, any abdominal.
So basically, everything was negative. Just he has a history of weight loss, which was insignificant, and loss of appetite. And there was no history of limb swelling, dyspnea, chest pain, cough or hemoptysis, neck swelling or hypertrophism.
Okay. I want to know,
Is there any specific question you would like to ask him related to the swelling itself? He said while he was having a bath, he noticed ball size. Where did he notice the swelling? Abdomen is a huge area.
which part of
So ask him where did he notice?
which quarter?
It was right lumbar.
Right number.
Yeah.
Now you think about right lumbar region. Right lumbar region is a very muscular region or a very distinct? There are muscles there, no?
Muscles.
And he's saying golf ball size. What is the size of a golf ball?
Should be around.
Well, what do you think? So if a man can feel a golf ball size of swelling in the lumbar region, where do you think it will be? I don't know. I mean, we are all just thinking about it. We have not seen the patient.
It should be parietal or
It should be parietal if we can feel it. Okay. And now within 4 months, it has increased from golf ball to cricket ball. So when something increases from golf ball to cricket ball, what other question will you ask?
Yeah, associated pains, weight loss.
Was there any sudden increase in the character of the pain is what is important. Anything else you would like to ask about this golf ball size of swelling or cricket ball size of swelling?
Since it's the right lumbar region, I want to know about this urine output, all those things. And
you want to know urine output? You want to know urine output? He came into the OPD, he didn't come in extremis, he just walked in on 4 months.
Limb edema.
All that he said is negative. Limb edema, he said is negative. Anything else you would like to ask him?
To know about jaundice, all this.
No, we are looking at a mass which the patient is able to feel.
Any pus discharge.
If he is able to feel it, he may be able to see it. You want to ask him whether he saw something else there? Was there any trauma there? So no. Inadvertent trauma he had and then, scratch his brain to find out whether something hit him there. Is there any swelling? Is there any redness or it? Is it can he feel it, and when he feels it, is it tender? It's different between just pain and tenderness. Pain is a symptom. When you touch it, is it tender? Is it hurting him? Can he move it around?
What the physical findings?
No. You ask this question. Yeah. This is how you probe. Without seeing the patient. Now you are just thinking of swellings in the lumbar region, and you have to probe this question.
Want to know physical findings, all inspection.
You will try to imagine the physical findings and ask that in the history, if you can.
First, in inspection, I want to know whether the patient can observe any swelling or any dilated veins on the abdomen, or like features like this, any sinus corpus. Just then palpation, I like to know the plane of the swelling.
Okay, right, carry on.
Hello.
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 No. I pass a message to the counter downstairs.
Hello.
No, sorry for the inconvenience. Actually, we got disconnected.
And Kamlesh, did the patient actually say golf ball and cricket ball, all these things?
Yes, ma'am. I asked him the leading question. What was the size?
Because does he know golf? I'm wondering.
Yes, ma'am.
Does he know what is golf? Like that?
Ma'am, he
Or
told
did he say-
me small ball size, cricket ball se chota karke, ma'am. Aisa he told me.
Acha.
Yes, ma'am.
Okay.
Yes. But I asked the leading question, ma'am, first. What was the actual size? Do you feel like? So he told like that.
Okay, yeah.
Yes, ma'am.
Yeah, I want to know the physical findings.
Okay. So nothing in the past history. No significant any family history. General examination was normal. For abdominal examination. So in structure, it was a single, approximately 10 by 5 centimeter size, oval-shaped swelling in the right lumbar region, extending into periumbilical region with normal overlying skin, and it does not move with respiration. Confirm on palpation, it was a single form, non-tender, 11 by 6 centimeter size swelling in the right lumbar region, extending into periumbilical region with smooth surface, diffuse margins, and normal overlying skin.
Okay.
And the local examination.
Nice.
Yeah.
Yeah, I want to know whether it moves with the respiration and
It does not move with the rest.
the insinuation here.
We were able to insinuate.
Oh.
And on local examination, penis and external urethral meatus is normal. Prepuce was retractile. And the testes, both testes were normal in size and consistency.
There is a person in theatre who is in charge in theatre 1 and us. For that first case, that's why. You feed into methylene blue.
So the patient has got a mass in the right lumbar regions, so 10 and 11 into 5 centimeter. So it's not most of the respiration. Both testes normal also sensation. So it's more of a retroperitoneal mass actually. So we should be evaluating issue.
Retroperitoneal mass. Okay. What is your first diagnosis?
Why should a retroperitoneal mass be palpable?
If the mass
Or
is
rather, which retroperitoneal mass will be palpable?
yeah, huge retroperitoneal mass will be palpable. It's like
Arising from which structure? Which organ?
When you say retroperitoneal mass, there are a lot of structures in the retroperitoneum. Be specific.
yeah, retroperitoneal lymph node enlargement, then
Lymph node enlargement.
Lymph node enlargement.
yeah, tank.
But then, if you are thinking of lymph nodes, then in your history you didn't ask about testes.
The testes,
Because that's the most commonest thing we see, right?
they were told no cryptological history, no testicular pain, even examination.
Yeah, they said no, and they did not say on examination also. So then why are you Which retroperitoneal mass which is palpable 11/5, which we commonly see? Most commonly we see is from the testes, right? Which is palpable.
This age group
Do we
is
see something, anything else you have seen?
Since you said retroperitoneal mass, that's why these questions are being fired at you. And you said lymph node.
lymphoma maybe there.
No.
Yeah.
You could have lymphoma, agreed. You could have large lymphomas like this. You can have large
Yeah, you can have sarcoma, yeah.
What else? There are other structures where large masses are palpable.
Yeah.
You have forgotten the most important retroperitoneal structure.
Kidney also.
Yeah, kidney is retroperitoneal.
Yeah,
Commonest.
kidney is the most commonest thing, right? Why are you saying lymph node?
Considering this age group,
No. Even considering this age group, kidney is still the commonest.
but the patient is totally asymptomatic.
So what? We know it. We know it. Patient is asymptomatic. If you are looking at retroperitoneal mass, one side is definitely kidney. Can it be adrenal? It can be adrenal. Can it be retroperitoneal liposarcoma? Any of those soft tissue tumors can also be there. You have to go and seriatim. And only large lymph node will come. Because by the time you get a large lymph node, which may be related to testes, it will be apparent, number one. Number two, if it is a lymphoma, that also will have, this clinical findings will be there. The ones that come like this without any history, without anything, just a pain, are usually renal or retroperitoneal soft tissue tumors. That's all. Huh?
Among the renal, which masses are palpable?
Huh?
Like this? Among the renal, at this age, which are the masses which become palpable?
Squamous cell carcinoma.
Squamous cell carcinoma.
Squamous cell carcinoma, palpable mass.
Why? Palpable mass, we are saying. You think it will cause PUG obstruction and then be palpable? Why would it arise in the parenchyma? No? Means it would arise in the pelvis if at all. And squamous cell. Don't think of the most unknown things as the first thing. Most commonly, what is palpable at this age if it is arising from the kidney?
RCH is a common.
Okay. What else? What else have you palpated? This age group.
I don't know also.
Most common congenital anomaly which you think or which you can think of.
Huge obstruction, I don't know.
Oh, you can palpate fuses. There can be giant fuses, even which cross the midline. इतने बड़े रहते हैं.
Then you have a cyst also, a large cyst of the kidney.
Cyst.
Can this be a polycystic kidney? The other side may not be palpable, it will still be enlarged. Everything is not palpable. Maybe one side may be more enlarged than the other. Polycystic kidneys are also large and palpable. There are many conditions related to the kidney. At this age, we can be palpable. So don't think of the...
So exhaust them first. Yeah, because seriously thinking, I have not palpated many masses which are apart from arising from the testes. So I was wondering whether you have got such patients. Yeah, you could have got them because it's a different center. So
the other point that Dr. Sabapati mentioned is also important. That if this is a lumbar mass, usually all these retroperitoneal sarcomas or midline masses. So when they say
midline masses,
they are more renal, adrenal, those are the ones. So just looking at it like that, that's all. It's not that all these things are cast in stone, but these are things that we look at, we see commonly. That's all it is. So don't think of squamous cell carcinoma as the commonest. Why did you think of that? Carry on. Hello?
Yes, sir.
Yeah, carry on.
So what investigation would you like? We have finished exam. Oh, you're telling him. Okay, tell him.
Yes, sir.
Sujata? Sujata,
Yes, ma'am. Yes, sir.
you just carry on. I'm just going to see one doctor who has come downstairs.
Okay, sir. No problem.
So these are
Bobby
the
is not there. Bobby has not come today.
Sir, it's in rounds.
Okay, okay. Yeah.
so
So
these
if
are the
we,
these are the blood investigations, routine blood investigations.
Creatinine, just I want to know the
Serum
range.
creatinine 1.3.
Oh, so range, what's the normal range in the lab?
So it was 1.5 to 1.6. Upper board.
Okay.
Anything else you would like to know in the blood investigations?
I don't, yeah, it's enough. So I'll be going for a contest in the CT. So any of creatinine is normal.
Okay.
okay.
So I like to go for a contest and then CT of the abdomen pelvis. Yeah.
Okay. So these are the films. This is the axial film on contrast, and then I will show the arterial phase. Arterial phase.
Okay.
Coronal section. Okay.
So contents in the CT of the abdomen pelvis, which shows a heterogeneous mass in the right periaortic region. So when we can see the vena cava, so it being compressed actually, then right hydronephrosis is there. Periaortic region. Right periaortic.
Yeah. First complete the mass. How big is it? What is approximate size? What is its architecture like? Is it cystic? Is it
It's heterogeneously enhancing, madam.
okay? It is heterogeneously enhancing. What
So
else? Are there areas of necrosis, hemorrhage?
there's no obvious hemorrhage actually.
They will be seen as hypodense areas.
You can see yes.
So, is there any architecture to it? Is there calcification?
No obvious.
Is there AV malformation or increased arterialization?
Only heterogeneous densities are seen actually. And right hydronephrosis.
Okay, but you have to mention all these adjectives, okay?
Yeah, the IVC
Then is it invading the adjacent? Okay, IVC, yes. What about IVC?
IVC is not.
Is it, IVC is not visualized only, right?
It's not. It's being compressed.
Okay. Oh, is it really compressed or it is not filled up only?
This is aorta is filled up.
Aorta is filled up. Aorta is rounded in shape. It is not compressed. IVC is not seen at all.
Seen at
Or not filled up. Yeah. What else can you tell? What is the extent? So all these things we should say in one breath.
Yeah, depending
that
upon the
this
cut.
is a some 12.
Yeah, depending upon the cut, you can say it's almost 10 centimeter tumor actually, 10 centimeter mass. Yeah.
Okay, yeah. Yeah. Where is it extending from? Can you see the SMA?
Yeah, from the pancreas level, we can see, ma'am. Yeah.
Okay, from the level of the pancreas to where?
Almost aortic bifurcation also.
Okay. And then laterally and medially, is it crossing the midline? Is it encasing the aorta?
It's not, that's the fat plan is preserved, ma'am, so it's not encasing. Yeah.
Okay. So what is it called then if it is not encasing? What is the other word which is used? It is abutting, right?
So, yeah.
Yeah. So whether it is encasing or abutting, these words you should use.
Yes, ma'am.
Then laterally, how much is the extent?
It is crossing, midline the crossing.
Okay, medially it has crossed the midline. Laterally,
Laterally, it causes compression of the, it is not involved in the kidney, but the hydronephrosis is there.
okay. So if hydronephrosis is there and it is not involving the kidney, has it displaced the kidney anywhere?
The kidney looks
Has it
like
displaced it laterally, up and down somewhere?
not
No.
displaced.
What's happening to the ureter?
Just I want to see the cuts.
Okay, see them.
Up till here.
Yeah, it's enlarged. Yeah. The upper ureter is enlarged. Yeah, it's dilated. Yeah.
Yeah, that's true. What's happening to the ureter? You should see the ureter, nah? This kidney is functioning.
Yes, ma'am. Yeah.
You can't see the ureter. You have to mention it.
No.
What's happening to the psoas muscle?
Psoas muscle no infiltrate. No.
Okay. Yeah. Lower extent?
It's almost up to the bifurcation, ma'am.
Okay, now you tell all these things in one go. Let us see. Just practice. Or then you practice on your own later on. But try and say everything. Don't get so much prompting.
Okay.
Okay, try and give the entire picture. You know, this is normal das ka things. You should just go in a flow.
Yes.
What is happening in the pelvis? Bladder is normal?
That is normal.
Okay. Any other thing you can notice in the rest of the cuts?
Nothing significant is noted. Just want to
Huh?
that testis we have covered. I want to know.
What is this cut showing? Kamlesh, please show some more of the lower cuts, please.
Yes, ma'am.
हाँ ये देखो पीछे जाना प्लीज.
Yes, ma'am.
वन बैक नहीं उसके आगे. हाँ ये रुको अभी. Yeah, comment. What is the structure which we are seeing? Okay, describe all these things which are there. Which are the major bones seen here?
The femurs.
Okay, and
Femur and pelvic
what are
bones.
those? Okay, so what is there in between that? The pubic rami, what is there in between that?
It should be
And then come anteriorly. What is there? Yeah. So now describe testes.
So uniform architecture.
Which side testes it is? Which side testes are you going to describe first?
First, I'll describe the right side.
बोलो.
It looks uniform marketing, uniform density. There are no obvious calcification seen, and no areas of necrosis,
Okay.
no areas of necrosis or hemorrhage.
Okay. Yeah.
And
So
no
on
any,
CT, what are the features of testicular malignancy?
it's a hypodense. With this, in case of seminoma, it will be smooth, homogeneous architecture. In case of non-seminoma, it will be heterogeneous but hypodense lesions.
Yeah, and you may see some structures like bone, tooth, something like that, if you can see.
Yeah, that's
Okay.
seen.
What has happened to the cord? Can you mention? Can you see anything happen to the cord, to the outer structures outside the testes, its coverings? Something you want to comment?
Actually, no extra no extra testicular involvement is there. Actually.
Yeah, it's very difficult to talk on one or two films, but yes.
In this particular film,
Yeah. Okay. Opposite testis.
it looks normal.
Okay. So, what is your impression?
So, considering his age, I would, since there is a retroperitoneal mass and the kidneys are normal, so I would like to go for serum tumor markers for testicular cancer.
Yeah, I'm asking your impression after seeing this CT scan.
It's a retroperitoneal mass.
Okay, fine. And what is the testicular mass?
Testicular mass, I am not very able to.
Yeah, just a guess.
It should be GC germ cell tumor should be.
No, I'm not asking histological diagnosis. Is it a testicular cyst? Is it a mass? Is it a tumor, or is it an abscess, or like that? Radiological diagnosis, not histological.
No definite mass or cyst is seen, ma'am.
Okay. So what do you feel this could be? Could it be a tumor? Could it be an abscess? Could it be a hematoma? Could it be?
It could be tumor. Could be a tumor only. It's like in situ tumor like that. Otherwise, based on the based on the CT findings, I couldn't tell anything.
Yeah. Most likely to be a tumor. No? Because the testis is enlarged compared to the opposite side. It is showing a variegated appearance. The size has been deformed. Okay. On this basis, there is no typical hypotense areas or if we had done an ultrasound hypoechoic area seen. But okay, still then, yeah, it can be different.
And we have sonography findings.
So you want tumor marker? You have the report?
Yes, ma'am. I have the reports. I have the ultrasound.
Sure.
So on the ultrasound, testis echo texture appears heterogeneous with few hypoechoic areas and few foci of calcification. A well-defined hypoechoic lesion of size 7 by 8 mm is seen. It shows mild internal vascularity, prominent venous channels noted. And the tumor markers. So these are the markers.
Okay. AFP and the LDH are increased, ma'am. HCG is within normal.
Yeah.
So it should be.
Okay.
So we should think of a non-seminomatous germ cell tumor. It's whether it's since ultrasound is also suggestive of heterogeneous and hypoechoic lesion, so we can say it's gonadal origin non-seminomatous germ cell tumor with lymph node metastasis.
Yeah, so it is fair enough. If you can't visualize the testis properly on the CT or whatever given cuts, you can ask for an ultrasound.
Yes. Yes.
Okay, so this is your diagnosis. Non-seminomatous germ cell tumor of the right testis with metastasis to the retroperitoneum. So what is the staging? Can you do the staging now?
Stage will be.
You have got everything for the staging, or you want something more?
I want a chest X-ray, ma'am.
Chest X-ray was normal.
Chest X-ray?
Yes,
Do you want chest X-ray? Huh? In this case, when there is an 11 centimeter mass in the retroperitoneum, you will be happy with the chest X-ray?
The CECT is only for when the tumor marks.
To ask if you want. If you feel it is important, you have to ask. Is it important or is it not important? In C8 testes, will you do that staging on chest X-ray or CT scan?
The textbooks
HRCT.
describe chest X-ray is enough, madam. Only if when the tumor marks are very high or when there is a, then only they will recommend CECT. There is chest X-ray is the first part of the metastatic evaluation.
Tumor marks are high.
It's more than 10,000.
Okay, so when there is an 11 centimeter retroperitoneal mass, what are the chances that he having chest lesions which cannot be detected on a chest X-ray?
Yes. Okay. Yes.
No. If you are convinced, you ask. If you are not, okay, show him the chest X-ray then. Suppose this patient was your own brother, would you do a chest X-ray or would you just say CT is necessary only? I want to know everything. Chest X-ray can miss things. Do you accept that statement?
Yes, ma'am. Yes.
Yeah, then it's a huge malignancy gone to the retroperitoneum. We know the next echelon is the chest lymph nodes or the mediastinum. Then we need to know more things, right?
Okay.
We have to be, and without that, how can you do a proper staging?
Yes.
Anyway, the management won't differ much, but yes, we need to know entire things about the patient, right?
Okay.
Okay, but anyway, if you want chest X-ray, show him chest X-ray, Kalesh.
Ma'am, do not have the films for the chest X-ray, but his HRCT was done and it was normal, ma'am. It was done at Tata, ma'am, so it was normal.
Yeah, even if I would ask for an HRCT. Anyway, it's okay. So now what is the staging?
It should be advanced GCT, stage 2C. So nodes are more than 5 centimeters. So it should be 2C. No metastasis. So it's stage 2C. Advanced. It's advanced GCT.
Mm-hmm. Okay. Anything else you would like to know? What is your further management? You want any other tests, any other biochemical investigations?
It's liver, everything's normal, so no need for any further investigation. But I want to know the patient whether it's married or whether it's completed his family.
He is married. He is married and he is having 2 children.
Okay. So we have to counsel him for that sperm banking if at all he needs it. Yeah.
Mm-hmm. Okay.
The line of management, we have to plan for his management actually. So.
So what is management?
Since it is advanced GCC, we have to go directly for induction chemotherapy.
Okay, you don't want to do an orchidectomy, inguinal orchidectomy. You have a histopath diagnosis with you? Your diagnosis is on the base of the CT scan or the ultrasound.
But since in view of huge mass and raised tumor markers, and the patient has also got hydronephrosis, so we can go with induction chemotherapy and also.
You don't require a histopath diagnosis before starting chemotherapy?
Yes. This particular, when the patient is medically unstable, even we can.
Is this patient medically unstable, Kamlesh?
No, ma'am.
No, why is your hesitation in not asking for an inguinal orchidectomy? Isn't that mandatory before starting any malignancy, before starting treatment? Don't you require a histopathological diagnosis? Correct me if I'm wrong, no? But I was taught in this way that you have to have a diagnosis.
Yes, ma'am. But there are some exceptions where we can bypass the orchidectomy.
Yeah, but why do you want to do this exception? I would like to know. Means what is your hesitancy in asking for an orchidectomy? Does the patient say, no, I'm not going to allow it?
No.
Then?
The medically unstable condition is one of the indication.
But is this patient medically unstable? Why are you thinking of something hypothetical?
Oh.
Have we told you that this patient is unstable?
If the patient is medically unstable, then how will be fit for chemotherapy?
You have to treat the disease. So I will first proceed with the orchidectomy. Then, depending upon the risk stratification, we have to go for the chemotherapy according to the risk stratification.
Okay. Okay, what chemotherapy will you give?
Yeah, this patient is AFP is more than 1000, so it will be falling in intermediate risk. So we have to follow that DEP, bleomycin etopostate cisplatin 4 cycles chemotherapy.
Mm-hmm. So you just complete all the 4 cycles, or there is something in between? Some review in between?
Yeah, it could be like 4, depending upon the response we have to see actually.
So when do you assess the response?
It's after completing the 4 cycles actually.
At the end of 4 cycles. What happens if the patient can't tolerate therapy beyond 1 cycle? What about that kidney which is enlarged and hydronephrotic?
So we have to follow it to the. So it can be
functioning. Functioning kidney, hydronephrotic kidneys. So what would you like to do in a functioning hydronephrotic kidney with all this problem? What would you like to do with that kidney? Leave it alone or? Yeah, you can make it.
Yeah, either you leave it alone or do something. One of the two you decide.
Is it important to do something or is it okay to leave it alone?
Anyway, you have started chemotherapy, so you can see the response actually.
Mm-hmm. No, I'm not talking about starting chemotherapy. What is the value of addressing a hydronephrotic kidney in a patient or functioning hydronephrotic kidney in a patient who is going to undergo chemotherapy for testicular cancer? Suppose this patient's creatinine was 3 for some other reason. He's got chronic glomerular nephritis and he can have a testicular cancer. Would that make a difference?
Because the cisplatin
Hello?
regimen. We are starting on cisplatin regimen, so we should know the renal status.
Yeah, it is very important.
Its creatinine is 1.3 only.
No. Creatinine may be 1.3. What is the core thing that you want to look at?
GFR.
GFR, right? Now, these fellows are unhappy to give cisplatinum therapy when the GFR is below a certain value. So to optimize the GFR, a functioning hydronephrotic kidney must be addressed to improve the GFR so that instead of giving carboplatin, you give cisplatin because it's a better drug. All right, and you can then give the full dose rather than give one half-baked dose which will not have any effect. Just like antibiotics have to be, if you want to hit somebody with antibiotics, give the full, not just half doses. Chemotherapy you want to give, you give full dose if it's possible, so that you have the effect. So a hydronephrotic kidney has to be addressed. You can't leave it alone. Anyway, if it is non-functioning, that's a different matter. It's gone. But if it is functioning, then okay. So
I told you induction chemotherapy. After orchidectomy, then depending upon the risk stratification, you have to change the cycles of chemotherapy. depending on the response of the chemotherapy.
So how was this thing missed?
In physical examination, testis was normal. Sir.
Mm-hmm.
Even CT we couldn't appreciate, but in ultrasound they showed a hypocoagulation.
In the testis. Supposing there was nothing inside the test. Supposing the ultrasound also was negative. What is this mass?
And either burnt out testis also.
Burnt out testis. What do you mean by burnt out testis? The burnt out means testis doesn't exist there. But testis is there. But there's no tumor in the testis. But this thing, but the alpha beta protein is elevated.
Extra gonadal will be out.
Ah. You can get extra gonadal germ cell tumors. Huh? You can get, where can you get it?
Mediastinum, retroperitoneum.
Any of these areas you can get. Huh? So, it's important. That's why you find out whether testis was palpable there, not palpable there, leave it there.
Any lymph node in para-aortic or intra-aortic region.
Famous picture is there in K. Das, no? One hand here, in that. One hand in the neck, one hand in the testicle. Huh? So now you're giving chemotherapy. Then what will you do?
We have to see the response.
Okay. How will you see the response?
So it's again clinical and radiological things and tumor markers.
Okay.
So it can be complete response or a partial response.
Right?
Partial response may be marker negative or marker positive.
Okay. If the marker is negative, what will you do? Tumor marker has become negative and the mass is?
Complete response is both negative, tumor marker negative and no
mass. Right. That is one. Tumor marker negative, mass is still there.
That's partial response.
So what will you do now? Tumor marker negative, but mass is still there.
That's those two things are the.
No. What will you do?
Yeah.
What will you do if the tumor marker is negative after the cycles of chemotherapy, but the mass is still present?
So either you can go for second line chemotherapy or.
Go for some.
How will second line chemotherapy help if the marker is negative? How will you assess then? If the marker is negative, how will you assess whether the chemotherapy is working?
Is there any other method of assessing apart from markers?
Radiological.
Ask for it, no?
So CT.
Less than 1 centimeter. It should not be. It should be less than 1 centimeter. Residual mass.
Yeah, if it is
more than 1, it is. Yeah.
Okay.
So always see the initial size of mass, whether it is 50% reduction, or partial response, or complete response. These are the three words they expect. Complete 50% and no response. These are the three responses you have.
So you will see this. That's why it's very important to have these criteria very clearly mentioned as to what is the size of the mass exactly to be measured on CT scan. What is the response on CT scan? Okay. Same parameters have to be used. What will you do if the tumor markers are raised and the mass is still present?
Yeah, that is the disease progression. So there we should go for the second line chemotherapy and then post chemotherapy surgery we have to.
Yeah. Okay. So you can. Here, is there any role for surgery in this situation where the mass is still present and the marker is negative?
Yeah, there is a role.
What is the role?
Because it's a big mass actually.
Yes, 10 centimeter mass.
So post chemotherapy surgery you have to do it.
Okay.
What is that called? What are the terms used to say that?
So retroperitoneal lymph
No.
Some drugs are there.
There are certain. One is post chemotherapy, RPLND.
Yeah.
That is one category. That means the patient has had his full cycles of chemotherapy. The response has not been great, or the response has been partial, and you can't give anything more. So that is post chemotherapy RPLND. That is one category. The second category is where the patient has had one dose of chemotherapy, no response, marker is still. Second dose of chemotherapy, then
Salvage chemotherapy.
salvage chemotherapy also given, and the mass is still present. So what do you call that sort of surgery?
It's a desperation surgery.
Okay. So in that operation, what can be removed? In that desperate situation, what are you allowed to remove? And in which situation will that operation be actually contraindicated?
Late pregnancy.
When would RPLND not be feasible? In which situation will RPLND not be feasible? Oh, you cannot do it. Leave it. You cannot fight malignancy. Which locations in the retroperitoneum and the abdomen where disease happens is it beyond? So I asked you, what are the things that can be removed? What are the things that cannot be removed? Can you remove aorta? In our brain, why? Can you remove? Photograph.
You have to replace it.
Replace it. No. Can you remove superior mesenteric artery? You cannot. You cannot remove superior mesenteric artery. Can you remove hepatic artery? See, the whole abdomen, you can take everything off and send it to the morgue. Send the fellow to the morgue. But what is it that's technically feasible, possible?
Yeah, so involvement of the SMA, hepatic artery, these are all encasement.
What are hepatitis
Where-
and SMA are areas where you cannot do anything. Beyond
You
retention.
cannot do anything. Yeah.
You can replace the IVC, you can replace a bit of the aorta, all that is possible. You can take out the whole area, you can take out a kidney also. Huh? So there is a place for where you cannot do anything more. So where are we with this patient?
We have only started chemotherapy.
Okay.
So you have
So
done
one second.
architectomy you have to do, sir.
Orchidectomy has to be done.
Yes.
Which side will you do orchidectomy?
The right side.
That's where the ultrasound has shown a hypochondrial lesion.
We have to see what's it.
I could still not understand your reservation in not doing an orchidectomy when ultrasound and CT both are indicative that there's something wrong in the right testes.
Yes.
Means maybe something new has come up I'm not aware of.
You do the right architectomy. Then depending upon the
No, but then why didn't you do it before starting your chemotherapy? If you want to do it, then why did you delay it? Initially, you told me you will not do it. That's why we went on this discussion about BEP. But I still didn't understand. Why is your reservation there? A person who has already completed his family, he is married, he has no objection.
You got confused. Huh?
The medically unstable condition is.
Medically unstable condition. Yes, the fellow was unstable. He's very unstable. He came and
But
walked.
this patient is not medically unstable. This patient, now for the third time, we are telling you that he is not medically unstable.
Initially, I thought that then told.
He got confused. Right. Okay. Right. In which situation, now that you raised the issue, in which situation will we not be able to do the orchid? We would rather give the chemotherapy and not do the orchid.
Yeah. Which situations? It's
Yeah, because the patient may be in IVC obstruction and dyspnea also. Like,
So what? Like what? Which situation is that?
patient may be in dyspnea also.
No. In which condition does that happen usually?
It's mediastinal retrograde nodes.
No, we are talking about orchidectomy. The question that you raised was, I will give chemotherapy and not do orchidectomy. And madam was asking, why were you delaying the orchidectomy? You said you got confused because he was medically unstable, but he is not unstable. So I am asking a question related to that scenario.
It's medically unstable.
Where will you? In which situation will you give chemotherapy? Forget this bloody orchidectomy. No.
There are some more situations where you can do that.
So sick. So what are those situations where he is very sick? And doing that orchidectomy will be dangerous to his life. Otherwise, removing testes is a piece of cake for most people. In which particular situations is that risky? Now, what type of situation? You said mediastinal nodes and you said dyspnea. All right. Concede it. Mediastinal node, dyspnea, you can't wait. Anything else? More common than that, actually. This mediastinal nodes causing dyspnea is a rare phenomenon in testicular cancer. It is a common phenomenon in Hodgkin's lymphomas, where you get SVC obstruction and mediastinal compression. That is more common. For some strange reason, this testicular one does not cause this. Stops at this level and goes here. And what happens in the mediastinum, you don't even know. It goes straight to the supraclavian. So, which is that particular situation related to testicular cancer, where you want to give upfront chemotherapy because this fellow is sick? And what is it that causes that sickness? Apart from mediastinal nodes. He doesn't have
Brain metastasis.
brain metastasis.
That's only Korea person.
You are giving an answer and then refuting that answer also at the same time. You are saying brain metastasis that happens only in choreography. Say something.
But orchidectomy is such a thing that if you are thinking of chemotherapy in a medically unfit patient, orchidectomy is the most simple thing to do. Chemotherapy is more difficult. You have to have 10 parameters right before you can start it.
The situation we are talking about is an anticentric testis, abdominal testis, which has gone missed, which has become large. His patient has got ascites. It happens, peritoneal metastasis, ascites. There you do upfront chemotherapy because the markers are elevated. Based on the markers, you go ahead and start treatment, get him better, and then go ahead and do the operation. You take out that mass. Okay? These are very specific situations in testicular cancer. They are rare, but they do occur from time to time. These fellows are very sick when they come with this. Wasn't there a webinar on carcinoma testis recently? There was recently a webinar on carcinoma testis. Huh? 2 weeks back, yeah. I think not KE, what is it? Tata was conducting it. I'm not sure, but I think through the SOGO or through USI, I think, webinar. I don't know. SOGO, no? I think you guys must get onto the SOGO app also for malignancy. They have some good programs. Anyway. So now what's the situation with this man?
Yeah, only CT and ultrasound have been done. Tumor has been done.
Okay.
So we'll do
Now you will do orchidectomy.
Radical eye orchidectomy. So depending upon the histology findings and already tumor markers are there. So you will post orchidectomy tumor markers you have to see. Then you have to stage and.
So here the markers were done before the orchidectomy, isn't it? And you started treatment before the orchidectomy.
You have to do the tumor markers.
Now you have to take out his testis and redo the thing. How much will you know is the effect of chemotherapy and how much will you know is the effect of the orchidectomy?
First you have to do orchidectomy.
Yeah, you do the orchidectomy now.
Then
Okay. Has he had any chemotherapy already?
No.
No. Okay, right. So
you have to reassess the tumor markers.
You'll have to see that. So we have to restage it. Right. So you've done the orchidectomy?
Yes, sir. Orchidectomy has been performed.
Yes.
It was not performed by us. It was performed by General Surgery Department.
Oh, I see.
And then
So
the
this
patient.
patient come to you all. It came to general surgery.
Yes, sir. Patient came to General Surgery.
Yeah, this patient was, means many times it happens, sir, that general surgeons don't refer it to us. They take our opinion. The most funny part is they want us to opine whether to do radical cystectomy, not to do, what to do, but then they will not refer.
Right. Very good.
So the histopath for the orchidectomy has come, Kamlesh?
No, ma'am. It will come today, ma'am. Today or day after today. Or tomorrow.
Okay.
Yeah,
So
it's-
tomorrow we'll tell them then.
Yes, ma'am.
Hello?
Yes, ma'am.
No, couldn't hear anybody.
No, Sarah's left, ma'am.
It's a thing.
So, shall we, ma'am?
Yes.
So,
Yeah, we'll leave the meeting here.
yes, ma'am.
Thank you, ma'am.
Okay. Bye. Thank you.
Thank you, ma'am.